going to be talking about vascular and extremity trauma. We'll get started with some of the questions first. We have the polls. So these were the cases that were sent on. I'm sorry they came a little bit late today, but we can just kind of go through each and see if anyone want to answer them. So we'll start with is the poll okay? Everyone can see the poll? Yeah, you got it. Okay, so let's do the first one. So a 13-year-old girl who's playing soccer, when she tries to kick the ball, she twists her ankle and falls to the ground. Her right ankle is swollen and she's able to stand up and walk on her ankle, although she says that it hurts. Your exam shows some tenderness over the anterior medial malleolus. Using the Ottawa ankle rule, how would you care for this patient? So we have four choices, A, B, C, and D. We can get a CT, we can get an X-ray, we can get an ultrasound, or we can send her home with pain control. You should be the answer on the poll. Is the poll working okay? Does everyone see it coming up? Okay, we respond. Oh, we respond in the chat. Okay. Dice, you say B, D. Anyone else want to respond in the chat? B.
I'm on my phone, sorry,
okay.
and I'm not really figuring out how to do it very easily instead of my computer.
Oh, so the poll doesn't allow you to submit unless everyone submits. Okay, we can also respond in the chat. That works too. Everyone can see it in the chat. So number of answers, B and D looks like are the two ones we see. So there's a couple ways we can care for this patient, right? Like here, if we're following the Ottawa ankle rule directly, basically if there's pain just over the anterior part of the medial malleolus without any pain over the posterior part, we don't need an X-ray given that she can walk. And we'll go into this these rules in a little bit later, later in this lecture. But if we were just to go off of this rule specifically, we would the correct answer here would be D, discharge her home with ice and ibuprofen for pain control. But again, there's a lot of ways to kind of to care for this patient, taking into account patient preference and the family's preference. So, getting an X-ray of the ankle wouldn't be wrong as well. But if we're following the rules specifically there, we would, she would be safe to go home. Let's go to our next question here. You have a 56-year-old fisherman who presents to the emergency room after falling off his fishing boat. His right ankle is obviously deformed and there's a small 1 centimeter laceration over the ankle with no exposed bone. His X-ray shows a distal fibular fracture. What is the first thing you should do for this patient? So we have a number of answers. We can give antibiotics, we can splint the ankle, we can give the patient crutches, or we can see if the patient can walk. Let's see. B. B. There are a couple of B's here. So that's definitely one thing we can do, given that there's a fracture, you do want to split the ankle. But one of the important things that we want to do here is give antibiotics because this is an open fracture. If we have a fracture here and there's a laceration kind of over where the fracture is, and these patients have a very high risk of getting infected, of getting septic, of getting osteomyelitis or infection in the bone. So while you do want to split the ankle as well, one of the important things we want to do here is A, which is give antibiotics. And you want to do this every time you have a fracture with a cut or an injury over it. You do want to give antibiotics there. Let's look over here as well. So our next question here is a 78-year-old male who's brought into the emergency room after a motor vehicle accident. He was a restrained passenger in the front seat and his knee hit the dashboard. A CT scan of the hip shows a posterior dislocation. So what is a common complication if this hip is not reduced? It's an inguinal hernia, a urinary tract infection, low back pain, or osteonecrosis. You can answer in the chat as well. I think the poll doesn't seem to be working here. Any other answers? We have A, we have D so far. Anyone else want to give a try? Good. So yeah, so D is correct here. So hips that are dislocated are an orthopedic emergency, and if they're not reduced pretty quickly, usually within like they can definitely cause osteonecrosis or avascular necrosis, especially at the head or the neck of the femur. And again, we'll kind of get into all of this in a little bit as well. Last question before we get into the lecture here. So if a 45-year-old male who misses the step on a curb and falls to the ground, your exam shows a dislocated right knee. Which artery do you want to make sure is not injured or damaged? The femoral artery, the brachial artery, popliteal artery, or carotid artery? You have one answer for A. And some answers for C. Yeah, so the answer here is C, right? So the femoral artery is important to evaluate as well if you're concerned about an injury. But the main concern we're worried about during a dislocated right knee is the popliteal artery, which kind of runs behind the knee. And it's it's one of the arteries that can get injured and swollen. And we want to make sure that's not ruptured or lacerated before we kind of continue on with the exam there. But great job. I know these cases can be kind of tricky sometimes. So let's move on. So the first part, we're going to be talking about vascular and orthopedic injuries today. And you can also just respond in the chat. Which one do we think will kill a patient first? Vascular injuries or orthopedic injuries? Which one are we kind of worried about first? Vascular, right? Exactly. So vascular injuries here are part of the ABC. So when we assess for airway, we assess for breathing, and we assess for circulation. Vascular is all part of the circulatory, the C part of our trauma evaluation. And so, when a patient's bleeding out, they can bleed out very, very quickly and become unstable or hypotensive. And that can all kind of contribute to morbidity with the patients, right? So again, when we're doing the ABCs, vascular is part of the C. Some of the hard signs of, there's hard and soft signs. So if you have a hard sign of a vascular injury, these are times we need an emergent vascular consult. So anytime you have loss of distal pulses, you can't feel the radial pulse or you can't feel the DP or PT pulses in the legs. Anytime you have pulsatile bleeding, like blood is kind of pumping out of a vascular wound. If you hear a bruit or a thrill, anytime you have expanding hematoma, cyanosis, or a leg which is pale and cold, these are all hard signs of a vascular injury. You need to get vascular involved right away because they may need to go to the operating room. Tourniquets are one of the things we kind of, we see a lot. Otherwise, onto the turn. Wherever you're bleeding, you just want to prevent it from worsening and bleeding out. So the next So we're going to get into some different orthopedic injuries, and there's a number. We'll get into some of the kind of orthopedic emergencies that we see before getting to some of the more uncommon orthopedic injuries. So some of the orthopedic emergencies, the first one's for open fracture. So this is kind of what we talked about a little bit earlier. Anytime you have a fracture with an overlying laceration or abrasion or wound, these patients are at very high risk for osteomyelitis or the infection of the bone. So if you have a grade 1 or 2 like breakage of the skin, you can use an antibiotic like Ancef or cefazolin to cover for antibiotic treatment there. But if you have a grade 3 injury, which is basically extensive soft tissue, muscle, or nerve damage, or a very dirty wound, you want to get ceftriaxone and vancomycin into the patient to kind of help them fight off the infection. All of these patients need an orthopedics consult emergently, and they have to be washed out and debrided in the emergency room. So usually orthopedics does that, but it'll take kind of several liters of normal saline and fluid and kind of rinse out the injury before they do the repair there. You also want to give the patient tetanus prophylaxis, so make sure they're up to date on their tetanus shots because these wounds are very dirty and they can lead to infection spreading there. A couple interesting notes: if the patient, has an injury with some fresh water in it, you can consider giving ciprofloxacin to cover for some of the bacteria found in fresh water. And if they have saltwater contamination, then you want to consider doxycycline in order to cover for bacteria like Vibrio. Any questions on open fractures before we move on?
Hey, Jonathan, maybe I can jump in really quick and just reiterate that the importance of timing. And so if you even suspect an open fracture, like you see that something's deformed and there's a laceration, there is a lot of data that says that the sooner you get the antibiotics in, the better. And it does make a difference. So I know where I work, this is actually tracked. And so the goal is antibiotics in the patient within an hour of them showing up in the emergency department. And so I think that just stresses how important it is. So it's better to give antibiotics and then find out later that it actually wasn't an open fracture than it is to wait, because these actually have such a high risk of causing systemic infection and of really risking the joint itself. So I'm glad you brought that one up. I actually feel like lately I've had so many just dirty wounds. So they're dirty open fractures.
Yeah.
So I feel like I'm always giving a lot of antibiotics for this.
Else have anything to add as well? Either like your practice in Utah or in Vietnam, any other or interesting cases you've seen or questions?
I think the same in Vietnam. We have an antibiotic with the open fracture.
You also do the same thing. You give antibiotics for open fractures in Vietnam.
We have a cefazolin too and ceftriaxone, vancomycin too. All right, and they usually give it very early, as soon as possible, and after that they go to the OR, and we just get antibiotic in the ED.
Okay. So our practices are pretty similar. It sounds like in different communities, our practices sound pretty similar there. Let's go on to the next one. What do we see right here? Do we see a normal pelvis or a fracture somewhere? You can respond in the chat too.
This fracture is open book fracture.
Oh man. Yeah, this is a pelvic ring fracture, right? So we see a number of fractures here. Actually, we see them right here and right here and right here, and possibly a little bit right here as well. This is a pelvic ring fracture. So this is another type of orthopedic emergency, right? So it's very hard to break someone's pelvis. It's one of the pretty strong bones in the body. So these are really high. It requires a really high energy impact in order to get the pelvis broken. It's often broken in multiple spots. So this is what at least for medical school for us, it's described like a pretzel. Like usually if it's broken in one part of the pelvis, there's going to be another fracture somewhere else, just because of the ring here. It's hard to break just one part of it. Because it's such a high energy fracture, it's very important for you to examine all the other parts of the body for injuries as well, right? So we especially want to look at the chest, look at the head, look at the abdomen, and do a good genital urinary exam to make sure there's no other injuries there. So you like blood from the urethra or like a high riding prostate. Those are all kind of signs that the genitals may be injured. So we just want to do a really good exam and make sure there's nothing else injured just because of the amount of force it takes to break the pelvis here. You likely will have to start, you should definitely consider massive transfusion protocol. There were a lot of, arteries and veins that kind of go all throughout here along the pelvis. And when it's broken, you have a very high chance of injuring some of those and having a lot of blood in the pelvis. Kind of like we talked a lot about ultrasound in the FAST exam, but you can definitely, when you're doing the suprapubic portion of the FAST exam, you should definitely be very careful to look if there's any free fluid or any blood in the pelvis that can come from a pelvic fracture. You can, if you do see a pelvic fracture, you suspect one, you can do a pelvic binder to kind of hold everything into place to prevent, worsening bleeding. And these patients require an orthopedics and a trauma consult. There is, and this is an example of a pelvic binder. There are a number of ways to do it, but you want to make sure you're kind of low enough along the where the head of the trochanter is to really kind of hold it into place. I think a lot of people tend to put a little bit too high up, so you want to make sure it's down at the widest part of the pelvis so that you're able to tighten and hold it together, and that can usually help with some of the bleeding there. The next orthopedic emergency we have is a hip dislocation. The majority, about 90%, are posterior, and the very classic example is someone who's riding, in the passenger seat of a car that suddenly stops and they hit the knee against their dashboard, and that can, in patients who are older or who have non-native hips that were replaced, that can sometimes lead to a hip dislocation. Again, these are pretty uncommon. These are just the very kind of more high-risk orthopedic emergencies that we see. Whenever you have a hip dislocation, you do want to look for any associated hip or pelvic fractures. And these can be really hard to see on x-ray. So when you do see a dislocated hip, you should definitely consider getting a CT scan to see if there's any associated fracture around the pelvis or on the acetabulum there that could make reducing it very difficult. And again, if you do have a hip dislocation, this is an orthopedic emergency, and you do want to do closed reduction within the first 6 hours to prevent any signs of osteonecrosis, assuming that there are no fractures. If there is a fracture, we would talk to orthopedics to see if they wanted to do, an open reduction there. One of the techniques for reducing a hip is like what we call the Captain Morgan technique. So basically you would, you can see the patient's laying flat, and you would take the patient's leg and put it over the provider's knee, and you basically want to pull up here on the femur part and down here on the leg. And that has some success in kind of reducing hips, but Shakira, Matt, or Claudia, or anyone, I'd love to hear if you have any other experience with reducing hips. I'd love to hear that, or however you do it in Vietnam as well.
Jonathan, I'll jump in really quick, but I would be curious to see what other people say. I really struggle with these. I used to try the kind where you get on the bed and you hold the hip and twist. And I've successfully done it, but it takes a lot of effort. Like, I feel like my technique is not good. I actually really want to try the Captain Morgan. I helped with one just last week where they did this, and it worked really well without actually requiring a lot of grunting. And so I am not exactly the strongest person usually in the room. And so I like this technique, because I feel like it requires more finesse than strength. But I'm really curious to see what other people do, because this is one where I do have a little bit of dread every time someone comes in with a hip dislocation, because I really don't want to do it. So yeah, that's kind of what I'm at, but I'm still working on it.
In Vietnam, we do it in OR. We don't do it in emergency. It's dangerous.
Oh, so you never do it in the emergency room, even if it's closed without fracture, they still go to the OR, die?
Yeah, they do in OR with full anesthesia, and after that the muscle is relaxed, and they do it very easier. You do it in emergency, it's dangerous because they are so, painful, and it just, don't cooperate with you.
Can I ask, is that because you guys don't do procedural sedation in the emergency department?
Orthopedic will do in ER, and we prepare for everything for they do it in the OR operating room.
Yeah, that makes it tough for us. Like for my practice, I will use procedural sedation. So we use a little propofol, just have everything set up if we need it. So we have somebody from the respiratory therapist there and people to help with that portion of it. And we give a little propofol, and that allows the dislocation. That allows us to do the reduction right in the emergency department. But I can see why doing a hip without the sedation is really difficult, because it is a tough one without some sedation. And what you were saying, Shakira, I'm Claudia, the new fellow from Utah, by the way, and I cannot do the Captain Morgan. I'm a 5'1" girl, and so like my leg height does not work for that technique. So it just doesn't work for me. So I always get on the bed, but that's because I'm really small.
Oh, Claudia, I didn't even think about the leg height though. All right, I'll have to see if my
it doesn't.
I don't.
It doesn't work. Like unless it's another really small woman, it doesn't work, because like my shin height is so much shorter than their leg height, like if you look at the picture, so it never works.
Okay, well, I might skip it then. But that was really helpful to hear.
You could try it. It's like
if
it's somebody that's similar height to you. Yeah, if it's somebody that's similar height to you, it would probably work. But there's very few patients that are also 5'1", so it doesn't work for me. Yeah.
For our next one here, what do we see here? Is this a normal knee or is it a dislocated knee?
It's located,
right.
So dangerous.
Exactly. So this is an anterior dislocation of the knee, right? We see the femur here, we see the tib fib and the patella here, and this is a dislocated knee. So again, knee dislocations are, these are very high energy traumatic injury. In order to get a dislocated knee, you really need to have disruption of several of the ligaments, right? So there's the anterior cruciate ligament, there's the posterior cruciate ligament, and the medial and the lateral cruciate ligaments that hold the knee in place. And in order for it to become dislocated like that, you probably have to tear at least 3 of the 4, if not 4 of the 4 ligaments there to really get a dislocation there. The most important parts here is to get a good neurovascular exam and get some imaging. If you do suspect any neuro or vascular deficits, you should go ahead and reduce this knee immediately. You will apply traction to reduce it, which will show a picture later on. If you have any hard signs of vascular injury, kind of what we talked about at the beginning, you should get a vascular consult for this, which is right behind the knee. And if you see any kind of soft signs of vascular injury, you can consider an ABI, like an arterial brachial index, to kind of check for them. But ultimately, the best thing to do is to get a CT angiography at the lower leg. That will look at the arteries and all the vasculature there and see if there's any injury or any leakage or any hematoma that's forming. So this is an example of how to reduce applying traction to reduce the knee. So you basically have one person holding up there, holding onto the femur, and another person on the bottom applying longitudinal traction to the tib fib, and basically like pumping the knee back into place. So again, if you see something like this in the trauma room and there's any kind of neurovascular injury there, you should reduce the knee. Wait, so you're saying that in Chile, the ortho will do knee reductions in the OR as well?
Yeah, in Chile we do OR too.
Oh, okay, that's cool. That's good to know. Yeah, these require emergent reduction just because, especially if you have any kind of nerve injury or any kind of vascular injury there. And our next one, this is an example of what we call a posterior lateral knee dislocation. It's known to be irreducible. It's like the one kind of knee reduction you wouldn't reduce because it can cause skin necrosis, which you can see right here. It's pinching the skin or tenting the skin right here. But you know, some people, tends to have to go to the operating room to do. But I'm curious if anyone else has experience with posterior lateral knee dislocations.
I feel like they're pretty uncommon, Jonathan. Like I'm trying to rack my brain here. I think it's been a few years since I had one like this. And I think the last time I had one was from a car accident. I actually think we did reduce it in the ER, but I think it was just because all the operating rooms were full. But then they very quickly took them to the OR.
You did sedation for that too, like an ortho?
Yeah. Yeah, we actually had a patient who was hypotensive and had that, and we actually tried to just pull on it while they were distracted.
Yeah.
And it actually worked a little bit because we realized we couldn't sedate them when they were altered and their blood pressure was low. So as we were turning the patient to look at their back, we kind of pulled on the leg, and it actually worked pretty well. It was very mean. Very mean to do, but worked pretty well. But we still had to do one after they're more stable to get it like perfectly aligned and splinted. So I wouldn't necessarily recommend that, but it kind of worked.
It works sometimes in the past. Let's see. So that is those are our orthopedic, kind of the orthopedic emergencies that we can get associated with trauma. In the pelvis fracture, the hip dislocation, the knee dislocation, and the open fracture. So next, we're going to go into a little bit more about the kind of not as emergent, but kind of fractures that we don't want to miss. So these are all kind of their fractures are a little bit easier to miss as we go along. So first, we'll talk about the Ottawa ankle rule. So this was kind of like in our question a little bit earlier about whether or not to get a X-ray of the ankle or the foot. So the criteria for this is for the ankle, if you have any tenderness over the posterior part of the lateral malleolus, or you have any tenderness over the medial posterior part of the medial malleolus, or if the patient is not able to walk after the injury and in the emergency room for 4 steps, if any of those things are true, then you would want to get an X-ray of the ankle. And the same thing applies for the foot. If the patient has any tenderness to palpation over the lateral part, kind of the base of the 5th metatarsal, the lateral part of the midfoot, or over the navicular bone, over the medial part of the midfoot, or they were unable to bear weight after their injury and in the emergency room, those are all reasons to get an X-ray of the foot. And I'm curious to hear about everyone's practice, but at least for me, kind of in practice, you know, if a patient comes in with kind of ankle swelling or pain, or they had some kind of injury, we tend to, like an X-ray isn't a lot of radiation, so I would tend to X-ray their foot just for reassurance and to make sure everything okay. So I know in my practice, I don't always apply the Ottawa ankle rule perfectly, especially, you know, if a concerned parent comes in with a kid with a twisted ankle and they really want an X-ray, I probably would get that for them anyways. But this is one of the rules that you can use to determine if you need an X-ray or not. But I'd love to hear everyone else's practice, both here in the US and in Vietnam as well.
For me, when people come to the ER, they usually get an X-ray. I mean, it makes them feel better. That's typically why they came to the ER in the first place. And it's easier to just give them the X-ray. Yeah, they're much happier that way.
Anyone from Vietnam want to share? Do you usually get, you know, if you have a teenager who comes in twisted an ankle playing sports, would you get an X-ray for them usually, or do you try to apply the Ottawa rules?
We do it all the time. Because it's very easy to get an X-ray, and then we feel good with that because we didn't have an accident, and I need the X-ray right now.
Yeah.
We get okay. We can do it. It's very easy.
You're such a hero afterwards, right? Yeah, Jonathan, I think most of us, I feel like I've talked to a bunch of people about this. I feel like most of us actually do the X-ray. I think those rules were originally derived And I feel like more useful in like outpatient settings where they don't have x-rays, but it's really hard. It actually takes longer to try to talk a patient out of getting an x-ray than it does just to get one. And so I also just end up doing it. I don't know if that's the right answer, but I usually give them an x-ray.
I think it gives a lot of people reassurance, but when they come in for that, but I agree. If it sounds like most of us will just go ahead and get the x-ray and just make sure it's pretty low radiation. So we're going to go through a number of different kind of fractures that in the arms and in the legs. So there's some very common fractures, like femur fractures or tib fractures. The ones we're kind of going to go through are ones that are kind of easily missed, at least in U.S. emergency rooms, and they can be kind of either uncommon or easy to forget about if we don't really consider it on our exam. We'll kind of go a little bit into why they're easily missed, how we can try to avoid missing them, and what happens if we do. So the first one, I don't know if anyone speaks French. I think it's a Maisonneuve fracture, but if anyone else wants to say it better than me, feel free to jump in. This is a spiral fracture of the proximal 1/3 of the fibula, and there's disruption of the distal tibiofibular syndesmosis. So basically the connection between the fibula and the tibia. And this is pretty high up. It's usually right below the knee. What happens is this happens when you have an ankle fracture or a sprain. So, if you have a twisted ankle with a lot of pronation or external rotation, a pretty classic example is if you have a twisted ankle in high heels. And the reason people tend to miss this type of fracture is because, someone coming in with ankle pain. If they twisted their ankle, they may have just, they may be on the ground, they may have been helped onto a chair, onto a stretcher, and never kind of bear weight again on that leg. So, you're examining the patient and you feel, they have tenderness over the ankle, they have tenderness, over there. You get an x-ray, you may see a fracture, you may see a sprain there. You may put them either in a splint or in like an ace bandage or something like that, and then they don't bear weight on it for a little while because of the pain there. So it's easy to kind of forget to examine especially that far up into the fibula, and usually the X-rays for the ankles don't catch that high up. So these are all commonly missed things as well. So some of the things we can do is, if you're suspecting a Maisonneuve fracture based on the mechanism, you want to examine all the way up to the knee, including palpating around the knee and the proximal part of the fibula. You do want to check for dorsiflexion and dorsal nerve sensation of the foot, because the perineal nerve kind of runs along the fibula to the dorsal part of the foot. So that's a part of the exam that you can double check and make sure they have sensation there. When you do imaging, you do want to get an X-ray of the knee or the tib fib to look at the proximal part of the fibula. And the reason why there's high morbidity for these types of fractures is because it is considered a pretty unstable ankle fracture when you have a broken fibula as well. And it does require an orthopedics consult if you have any widening of the ankle joint. So this right here is an image of a Maisonneuve fracture. As we can see right here, there's widening of the joint space right here in the ankle, right under the tibia. And over here, we see a fracture right here at the proximal part of the fibula right here. So this would be kind of what we call a Maisonneuve fracture. And if you just got the X-ray of the ankle, it's very easy to miss the fibula part. So we want to make sure we get a good exam and that we're considering this kind of mechanism and whether or not we need to image, a little bit higher onto the leg. See if there's any fractures there. Has anyone ever actually seen a Maisonneuve fracture? I haven't personally seen one before, but I'm curious if anyone has seen one before and how you caught it.
I always
Patient
like
would
this
be
one.
painful.
Oh, go ahead, Dai.
Patient would be painful, and we X-ray wherever they happen.
Mm-hmm.
So the fracture like that, the knee is so painful.
Yeah.
And I feel like, Jonathan, this is exactly why I think we get kind of tired of it, but our orthopedic colleagues really, really hammer with us that they always want a joint above and below the fracture we identify. And honestly, I feel like it's because of this.
Yeah.
And it's frequently missed. I can't think if I've ever independently diagnosed one, but I've definitely had patients who've been referred in for it. But I do feel like it would, again, be really easy to not catch it.
Yeah.
And ideally you'd be managing one fracture anyways, but I feel heavily on the radiologist to pick it up on image, which is not probably a good way to go, but yeah, I haven't seen a lot of these myself.
And they're not very common. I think, we see so many ankle fractures. Sometimes it's easy, but just image, kind of what hurts, and the ankle is what's hurting them, but it can be kind of a distracting injury, right? The ankle is what's hurting them. We image them, but we forget to at least ask or check if there's any pain higher up. And kind of like Shakira is saying, image if you find a fracture or any kind of like joint space widening, image the joint above and the joint below. The next one here is a Lisfranc fracture. So this is a fracture or a torn ligament of the midfoot, especially at the second tarsal-metatarsal joint. The mechanism is either a forced hyperplantar flexion of the foot or hyperpronation or hypersupination of a plantar flexed foot. So one common example, I guess, in the US would be is someone who's riding a horse gets thrown forward and their foot gets stuck in the stirrup. That's kind of the best way, I guess, to describe a hyperplantar flexed foot. But a lot of things, if you're, I guess sometimes if you're running or if you're ballet dancer, those are all kind of ways where your foot could be a little bit hyperflexed there. You could see that these are kind of tricky. On the exam, you could have some midfoot tenderness, or the patient might be ambulatory. One kind of classic exam, finding the great toe sign, where the great toe is pointing up or dorsiflexed. And this is because the tibialis anterior nerve running there can become entrapped. If you suspect a Lisfranc fracture, kind of any tenderness in the midfoot, you want to get your regular foot x-rays, but you also want to get weight-bearing x-rays. So these are hard to get, but you want the patient standing, and you would ask the tech to basically image do the AP lateral oblique view. We're standing or at least pushing the foot against, like the edge of the x-ray table or something like that. So we're applying weight and they're able to see if there's any widening of the joint space there. Again, management, if you see any kind of Lisfranc fracture or any widening of the joint space, this will require orthopedics consultation and likely surgery. And this is another one of the ones that are very easily missed. So here we can see the second tarsal-metatarsal joint here, and we see a widening of the space right here. Another way you can do it is if you image, x-rays of both of the patient's feet and kind of compare them side by side to see if you have any joint space widening there. That can kind of help give some clues as well. Our next section here is about slip and falls. I know this happened in, I went to med school in Michigan and residency in New York. So it got very cold there and icy. And this is slip and falls were something that we saw in our emergency room probably around like November, December, when the first snow fell and a lot of people were out walking. They didn't realize it was icy, that it had frozen over, and there'd be lots and lots of slip and falls. And there are a number of fractures here that we can, can be commonly missed as well. The first one is a Galeazzi fracture. So this is when you have a fracture of the distal radius with a radial ulnar joint disruption. And so what happens is this is a fall in an outstretched hand. And you want to make sure you get imaging of the wrist and the elbow because this is commonly, we're going to talk about the Monteggia fracture next, but you want to get the wrist and elbow x-rays. And this patient will require an orthopedics consult and likely operative intervention. So here is an example of the fracture of the distal radius with the radial ulnar joint disruption right here. You can see it both on the AP and the lateral views here as well. So there's a fracture and the joint is open right here. A Monteggia fracture is kind of in some ways the opposite, a little bit closer, similar but closer to the elbow. So this is a fracture of the proximal 1/3 of the ulna, and there's dislocation of the proximal radial head. So it's kind of, I guess, in some ways opposite to the Galeazzi fracture. This is the same mechanism. There's a fall and outstretched hand, and you want to palpate for any kind of dislocation, elbow tenderness. You want to see if there's any pain with supination, and you want to check the thumb extension function because the posterior interosseous nerve runs between the radius and the ulnar, and this can cause some injury there, which may lead to thumb weakness. You want to get a wrist and elbow x-ray. And this also requires orthopedics consult and likely operative intervention. Anyone have any other experience or recent cases with Galeazzi or Monteggia fractures?
We have it all the time in
You get all-
Chennai.
What is it from slip and falls, or how do you see when do you see them?
Yes, maybe slipping or some accident. So most of them will have a cast for maybe a week. After that, they will operate it if the solution is not good. So most of them will operate. But first of all, they will make a cast for a week. That's my experience.
Okay. So you cast them. Oh, so cast them for a week, and then ortho will operate on them a little bit later.
Right.
Awesome. So we look at this fracture ready. This right here is a normal wrist. And there are 8 bones in the wrist, which I think we all memorized at some point, but they're not the easiest to remember here. So here's a diagram that kind of describes where they are. Some of the commonly missed wrist fractures. The first one is a scaphoid fracture. So this is the most common wrist fracture that we see. Again, the mechanism is a fall on an outstretched hand, and these are also very easily missed. So for your exam, there's a couple ways to examine to increase your suspicion for a scaphoid fracture. And that includes feeling there's any anatomic snuff box tenderness, kind of right here on the hand, feeling if there's any tenderness there, but also applying axial load to the thumb. So basically pushing and pulling on the thumb in the direction of the metacarpals to see if there's any pain elicited there. The initial x-rays can be negative, which makes this kind of fracture really hard to diagnose. And if you find a patient has anatomic snuff box tenderness or has tenderness to the thumb when you apply the axial load, at least in our practice in the US, we tend to just apply a thumb spica splint anyways, just because these fractures are so hard to see. If they're unstable, there's greater than 1 millimeter displacement, if there's any oblique fracture, rotation, or common unit fracture, those are unstable and they should definitely see orthopedics right away. You do want to do a thumb spica splint if it's just kind of tenderness there, but if it's unstable, you can put them in a long arm thumb spica splint. You want them in dorsiflexion and radial deviation. So you want them up here and off to the side a little bit. Orthopedics follow-up, and these can lead to high morbidity, including avascular necrosis if we miss them, which is why, if there's, based on your exam, if there's pain there, you can go ahead and apply a thumb spica splint. Right, here's the example of the fracture right here. You can see this is the scaphoid bone right here, and we see the fracture right here. I mean, again, these are not always obvious on the first set of x-rays. So sometimes we put on a thumb spica splint, we go to see orthopedics, they'll repeat the x-rays and see if there's any fracture there in the scaphoid. The next one, the perilunate and the lunate dislocation, these are also very commonly missed as well. They can lead to a lot of complications here. So in a perilunate dislocation, the lunate bone is in place, but the capitate is displaced. So this mechanism is the same thing. It's a fall and outstretched hand. What you see is on your exam, you'll feel dorsal swelling and maybe a little bit of a mass on the wrist. You do want to get x-rays and this requires surgical intervention. One of the main complications of injuring this is median nerve compression, which will lead to kind of loss of sensation in the medial part of the hand. We can see right here, there's some images. On the lateral right here, we see where the blue marking is right here. This is the capitate, and we see that it's displaced dorsal compared to the L, which is the lunate right here. And we know this is displaced because we can see the lunate right here is still in alignment and normal contact with the radius, which is here in green. So the lunate and the radius are in the same place, and the capitate is displaced dorsally here. Here's another view of it right here. On the right side, we see the radius right here, and we see the lunate in contact with that, but over here we see that the blue capitate is displaced. And on the PA lateral view, we can see kind of a loss of joint space between the lunate and the capitate. And for the lunate dislocations, this is kind of the opposite. This is when the capitate stays in place, but the lunate is displaced. And what happens, the same mechanism, fall on outstretched hand. Again, this is opposite to the perilunate dislocation. So in a lunate dislocation, you will see volar swelling of the wrist. So it's on the opposite side of the wrist. Imaging is the same. You would want wrist x-rays, AP and lateral. And for management, you want orthopedics for an emergent surgical intervention. The complications here include a possible median nerve compression as well, so similar to the perilunate dislocation. And here's some x-rays here. So on the AP view, we see that the lunate has a triangular shape, which you can see between the two green arrows right here. So this shows that it's out of place. The very classic view that you see on board exams is the lateral view right here, where we see that the lunate is off of the radius and is what we call a spilled teacup. So this is kind of the side of the teacup here. If you had tea here, it would be spilling out here. So that's a sign of a lunate dislocation on lateral X-ray. Median nerve, again, like it can cause median nerve compression, which will basically lead to paresthesias or loss of sensation in the medial part of the palm of the hand, and also on the fingertips of the first 3 digits and the medial part of the 4th digit. So the complications, again, for the perilunate and the lunate dislocation is medial nerve compression, which is why it becomes a surgical emergency and why there's so much morbidity that can be associated with this. And the last part, and this is, I know we talked a lot about different types of orthopedic emergencies, you know, the things not to miss, including the pelvic fracture, the hip dislocation, the knee dislocation. One of the things I think I learned a lot in residency was, you know, if a patient is able to walk when they come into or if they were able to walk before the accident the day before, you really should see them walk in the emergency room. So this can help us rule out a lot of the kind of dangerous orthopedic emergencies that we saw. A lot of the dislocations, the fractures, the patients wouldn't be able to walk. So if they're able to stand up and barate and walk around the exam room for you, there's a lot of reassurance there in knowing you're not missing a fracture, you're not missing any kind of other, you know, brain or electrolyte kind of abnormalities that's leading the patient to feel weak. That's all I have here. So does anyone have any questions, suggestions, ideas, anything else we want to discuss?
Jonathan, that was great. I will say that I feel like we see this so much more than we realize. Anytime you work at a center where trauma is the main thing, and so commonly the scariest cases are the vascular and orthopedic injuries together, right? It's like trying to figure out what the priority is. I will say, don't underestimate what happens when a patient is so sick that they're altered. I feel like we have one case at least every year that we end up talking about as a group where a patient came in and they were so sick they got intubated, and then either they had a missed bleed, like a bleed into the thigh from an injury, or a missed orthopedic injury that unfortunately we didn't notice until later. Understandably, you're still focused on keeping the patient alive, but I can't stress enough that this is really important and very important to be thorough, especially in patients who are altered and can't tell you if something hurts. So you will use this, and I'm sure most of you have already seen this in your practice, but this is a really great topic.
It's great topic, Jan. Thank you.
Thank you. Does anyone have anything else we want to share? Experiences with interesting orthopedic cases, you know, things you've missed?